I'm talking to Dr. Stephanie Dancer, one of our keynote presenters at the 2013 conference. Dr. Dancer, why is cleaning so important in hospitals?
Cleaning is very important in hospitals because the role of the environment in hospital-acquired infection is now becoming more apparent. Up until maybe 5-10 years ago, the role of the environment was not really regarded as very important for patient infection risk, but that's completely swung about just over the last couple of years with some innovative papers coming through screening the environment and modelling the results against patient risk and patient risk of infection for specific organisms. So I think that cleaning is very important. It's not yet universally recognised so though.
So if someone comes into a hospital or a healthcare facility and says, this place looks dirty, is it really dirty, or is it just our perceptions of it because we're so used to cleaning things?
I would always agree with the patient. If a patient thinks the hospital is dirty, they're probably right. There was a furore about a decade ago in the UK with patients complaining about dirty hospitals and their experience of dirty hospitals, particularly so because there was if you like, a rise of MRSA throughout the hospitals in Great Britain, and patients put two and two together, and their visitors, that there was a link between the two. And it was also at the same time that hospitals were getting more and more crowded. And this dirty, busy hospital is a risk for infection at that time was regarded as just patient speak and not really valid. But we actually have the science now to justify precisely that perception from patients that a visually dirty hospital is associated with higher microbial bioburden and an associated infection risk.
So you talk about visual dirt. How do you measure it? And if you measure something and you change a process and see that the result, is that science?
I think the answer to that is yes, definitely. You can, if you measure something using standardised scientific methods, and you can do that again and again, and you get the same sort of standardised results. Yes, of course, you can call that a science because you're measuring microbial dirt in the environment. The trouble is, we don't yet have universally agreed standards for measuring microbial dirt in the environment. When we do, and I think we will then be on a much better place to be able to model what's in the environment at the microbiological level against patient risk and look to see, well, what can we allow? What do we permit on surfaces in our hospital? When's the danger signal? When do the levels increase, which flags up a warning that patients might be more liable to get an infection?
Do we talk about antibiotic stewardship? So, because we can chop and change and edit all of this stuff.
Yeah.
So you talked about cleaning, about contact, about visual cleaning, which is something that will relate about the fact that it's a science. You can measure it and evaluate it, change a process, so it's measurable. So if we talk about Nelson, look, one of the issues that you raised, that has been raised at this conference, is the whole concept or the whole maybe the problem that we may be running out of antibiotics.
Yeah.
How are we going to deal with that? So I'll ask the question.
Yeah.
One of the issues that's been raised at this conference is the fact that we seem to be tending towards a world where there will be fewer and fewer antibiotics that actually work, and there may be no real antibiotics. What does this mean for us in healthcare?
I think the antibiotic era is coming to an end. The 20th century was a desperate search for magic bullets to treat patients with infection, and I think it was TB that really sparked off that search, although of course we all know the story of Alexander Fleming and his discovery of penicillin for Staph aureus. We've had a ball. We've had a wonderful time with antibiotics, with new classes and statements from very important people to say, we've beaten infection. We've got antibiotics for all the organisms out there. We don't need to worry about infection anymore. Well, that's not true. And all of us practicing in hospitals know that's not true. We're running out, and it's accelerated over the last year, particularly for the gram-negatives, so much so that folk are trying to manage patients with gram-negative organisms causing infection, for which we have very little, if in fact any, antibiotics left at all. So the end of the antibiotic era is fast approaching, and we need to decide how we're going to manage that, and we need to decide what we're going to do about finding a new strategy to treat infection.
Following on from that topic, what are some of the measures which we should be starting to think about now to deal with this situation?
Yeah. Well, I think there are a number of things we can implement right now to be able to preserve what remaining antibiotics we have for as long as possible. So if we do that, we permit more time for the researchers to come up with new strategies. And I think the most important thing of all is antibiotic stewardship. We're in this mess because we've been using antibiotics indiscriminately, inaccurately, across the world, and that's still happening in many places. Even in my own hospital with a strict stewardship programme, I still find patients on antibiotics when they shouldn't be on them. I still find patients on the wrong antibiotics, on the wrong dose, and so on. So I think the first and foremost thing to do is to look at antimicrobial prescribing in the hospital and in the community. I think there's plenty of evidence that there's quite a lot going on in the community, and see what measures we can put in place to target reduction of consumption across the board. And that will do more than anything to conserve what we have left. If I have to put my finger on the next most important thing to do to keep our patients safe, and that will be clean. And that's cleaning hands and cleaning surfaces, including medical equipment. And I think the focus on hygiene will become more and more important over the next decade as we start to run out of viable treatment options.
They seem fairly basic nursing and medical procedures, don't they? Washing hands, keeping things clean, providing fresh air. Why do you think did we lose the plot on this somewhere? So why are we rediscovering it now in 2013?
Well, the attention is focused on things like hand hygiene and basic cleaning and so on, and it hasn't been. And it hasn't been, I think, because of antibiotics. Once we've been complacent that we have a treatment for every infection, then the meaning of hygiene and the meaning of what is clean has been rapidly eroded, not just in hospitals, but in society overall. I mean, you can go and eat in a nice restaurant. You look at the smeary cutlery, or you look at the floor underneath the table, or you visit the restrooms in a nice restaurant, and you'll see what I mean about the erosion of the importance of hygiene throughout society. We're still getting patients with food poisoning in society. And I think there's going to have to be a massive reversal of culture when folk realise that we haven't got antibiotics anymore, that there are germs out there that can cause significant morbidity and mortality, and that the meaning of clean and the disruption of transmission between folk and between people and the environment becomes all important. I think then we'll get our definition of hygiene and what the definition of clean really means.
Can you do one more?
One more.
I'm just thinking, is there some way we can incorporate into corporate process, like you go to McDonald's, they have tabs for cleaning the toilets. There's a tick if the toilet's been cleaned and that sort of thing. It's built into their processes, which are repetitive, iterative processes in that production. Is there some way of getting standards for clean into commercial processes as a way of starting to educate the community? Is there a question around that, or an answer you could something you can construct?
Yeah, shoring up cleaning surfaces in a hospital. It's difficult. You're dealing with people who may not have English as a first.
Well, I might ask the question. So,
all right.
What I would say to you, let's talk about how
to improve cleaning processes in the hospital.
Yeah. Dr. Dancer, one last question. How can we? Dr. Dancer, one last question. Tell us your views on how we can reinforce cleaning processes, and that seems to be one of the areas where you've focused on in your presentations here at the conference. Cleaning processes in hospitals.
If you want to improve the cleaning in your hospital, the first thing I'll say is it's not easy, because we've got in-house cleaners and we've got contracted out. It tends to be more difficult with the contracted out because the contracts are fairly rigid. It's difficult to change things, and there's a loss of ownership with that. Sometimes easier to improve cleaning with in-house. There are all sorts of different ways to do it. You can put your fluorescent gel on sites and monitor whether it's removed. You choose your sites carefully, and you can feed that back to the cleaners along with an educational program. They do react, they react very quickly, and you can get a very significant improvement in cleaning just from that. Doesn't necessarily last long term. So you sometimes have to think of different strategies. It may be a complete revamp of the cleaning specification, making sure that you know exactly who has responsibility for cleaning what, and making sure that the highest risk surfaces are going to get the attention they deserve. There's a sort of reward program that you can build in to a process, and along with that, a method for reporting of deficit, for example, which could be welcomed by cleaners at the basic level if they feel they're able to report where cleaning is not going to plan, or if their efforts are rewarded in some way. I think there's a multitude of ways to manipulate your cleaning population to produce a much better performance throughout the hospital. But you have to remember you're dealing with people. It's a hard physical job. They're not paid very much. Sometimes English is not their first language. If you're sensitive and understand the predicament that they're in, and then also the fact that they take great pride in what they do, many of them, then I think you can find ways to improve the cleaning in the hospital, and that's the first step to protecting your patients from infection.
Dr. Dancer, thank you very much for your time here at the 2013 ACIPC conference.
Thank you, John.
We're at the 2013 annual conference for the college, and we're talking with Mary Potter, who's just joined as our consumer representative. Mary, tell us a little bit about what you see the role of a consumer representative is.
Well, basically I think it's somebody who knows a little bit, knows the basics about the area, but is able to, in effect, take a bird's eye view and just see things because they're not in the midst of everything. I guess in some ways a bit like the old proofreader who could read a journal, read an article, pick up word mistakes, but wasn't involved in the depth of the actual. You have to write that one out too. Okay.
So we might just say, as a consumer representative, have you had it? Why is it important that we have a consumer representative? So, Mary, why do you think it's important that we have a consumer representative on the council of the college?
Oh, look, I think it's really important. You see, Steve, what happens is that when you're a health professional, you know all about the area. You don't think about the actual person. What you're thinking about is the job, the clinical side of things, but not how a person is responding and the big picture. And so I think it's very important to have somebody who's willing to express other views that may not be palatable to the clinician.
Mary, do you think it's significant that the college has appointed a consumer representative?
Look, I think it's a really important thing, Steve. As far as I know, it's the first of the professional colleges who've done this. Whether it's to do with the fact that the college executive is mostly nurses rather than doctors, I think that nurses have a greater understanding of the role of the consumer as a human being rather than just a disease or a problem to be sorted out.
Mary, just in conclusion, can we ask what your background has been?
Yes, I trained originally in microbiology and biochemistry and worked in a number of different roles before children. After a long gap, I needed to try something different and studied in social science and hospital pastoral care, worked in that for a few years, and then of recent years before I retired, I worked with the Division of General Practice, liaising basically GPs, health service, consumers, and particularly in aged care and residential aged care.
So you bring a wide variety of experience both in science and in the humanities.
That's right, yes. I think quite apart from my own personal experience of hospital-acquired infection, let's put it like that.
Okay. Well, thank you very much, Mary, for taking the time to speak with us.
Fine.
I'm talking to Min Tanavasa-Lenny. She works in infection control in the Republic of Nauru. And tell me, Min, what are some of the issues for people working in this area in Nauru?
I guess the first thing is that there is no infection control structured programs in Nauru, as I found out. So I'm actually there in another role for ACIPC, but I'm actually helping out to develop their infection control program. I've also been travelling in the region and meeting other hospital people from around the Pacific, and I realised that there is no program support for infection control in the region. There has been some work done by WHO and ACIPC before, but that's all, there's nothing there now. It's not sustainable.
Tell me, Min, what might be, say, the 3 or 4 major problems that you see there that back here in mainland Australia we probably have no idea?
Okay, I think the first thing is that we need to have a program structure, just like we have, something similar. We need an infection control program. We need to have a nurse or someone to run the program. So we need support. So all of the governance issues with infection control program in Australia, we need to try and promote that as a quality activity that all of these islands need to follow, so make sure that they have good outcomes for their patients.
I mean, are there specific cultural issues around how you might introduce some form of infection control program and activities?
Definitely, I think there have to be some sensitivities. I think people who go and work in the Pacific, in particular, that's where I'm from, you need to understand what of the cultural context. Some of the things that we do here and we kind of like push, over there are certain behaviours and certain ways that you could deliver and get the same outcome without trampling on cultural sensitivities.
I mean, if there was one short message that you would like to give to our members working in Australia, what would it be?
I think it's important to realise that the Pacific are our neighbours. They're our next door neighbours, and we need to engage with them to make sure that we are helping and support them so that they deliver good infection control programs and support so that the patients or the people in the Pacific have similar experience that we have in Australia.
I mean, you've talked about a mentorship program. How might that look?
I think it's an excellent initiative if we can get the college to be able to help and support in this area, because there's nothing exists there now. So what I would like to suggest is have a training mentorship program that we could engage the Pacific and us in Australia to deliver a program that is suitable and specific for the Pacific. So I could see huge advantage of doing such an activity.
And how long do you think that would need to be? Like, are you talking a month, 6 weeks? What might it entail? Coming to Australia and working and being placed, or someone from an ICP from Australia going and working with, for example, for yourself?
I think definitely the concept, you need to have both. Getting them from the Pacific to come to Australia and see what a real good ICP can do and deliver to make a program work. But also it's important then for someone from Australia to go back to the Pacific and deliver some form of training so that it's in their context. One thing is that you have to pick the right people to do this job, because it's very, very challenging. But it's very rewarding.
Okay, thanks very much, Min.
You're welcome.
You're right, that gives us plenty of time. Look, thanks though, I'm sorry though. Well, can you tell us about the different types of special interest?
Yes,
I might say that.
yeah.
Whenever you're ready. Annie, can you tell us about the different types of special interest groups?
Sure. We have quite a number of topic-based special interest groups, including cleaning, disinfection and sterilisation. That's one group. Residential care, mental health, including drug and alcohol. Then we have office-based practice, surveillance and applied epidemiology. And then we have special interest groups set up in each of the states and territories in Australia as well.
And how do these special interest groups operate?
Really, each special interest group have taken on a life of their own, if you like, and they're operating with different platforms. So some groups are actually meeting face to face. A lot of the state-based groups have continued with regular meetings that have been occurring for some time now. We have email discussion lists which are open to each group, and some groups are corresponding quite regularly with those email discussion lists now. There's been a number of seminars that have been organised and carried out in the States. And yeah, so that's the main ways really. The face-to-face meetings have been really successful to date with the state-based groups.
Annie, how do the special interest groups... Pick up. Annie, how do I get into a special interest group?
Okay, so when you join and become a member of the college, you're able to tick on the website which special interest groups you would like to participate in. So once you have done that, there's a lot of information on the website about each group and how they're operating. There's also a lead person for each group who forms part of the Special Interest Group Advisory Committee, and that person is able to coordinate activities and also lead you in the direction you need to go to in case you need some funding.
And how do I find the leads?
The leads are all on the college website. There's a list of leads and their contact details that are available on the website.
Annie, how would we go about setting up an interest group around a new interest or topic?
So we're now at a point where we're able to offer members the ability to join or to start a new special interest group, and that would be a matter of simply contacting me as the chairperson of the Special Interest Group Advisory Committee and making sure that we had enough interest. We'd then be able to set up you an email discussion group and start that discussion with you around what activities you would like to see put together for that group to kick off.
Annie, some of the ways that special interest groups have worked have been through breakfast forums or lunch and learn sessions on teleconference or lunchtime sessions, which I know you've run down in Tasmania, or journal clubs. What are some of the ways that people have used them to connect with each other? What, for example, does a journal club do?
A journal club really gets members together. They have access to a journal article before they come together, so they have the opportunity to read that. And we've set some parameters around how you actually would critique an article. So people are able to come together, they've got a formula, they talk about this article and critique it, and they're able to discuss it within a professional forum. So I think that's worked quite well, particularly in Victoria at this point, but it's something that we're establishing throughout the country and hope to set up in each of the states as part of a SIG activity.
And do you need any special technology for one of our, say, lunch and learn teleconferences?
No, all you have to do is have access to your phone at your desk, so you can sit there while you're eating your lunch if you like,
so you
and join in the conversation.
Lunch, do you?
You do have to provide your own lunch, yes, we're not going to do that for you.
What about down in Tasmania, where I understand you have lunch and learns in the pub?
Yes,
in the
we
Mount
have
Ross
very
Hotel.
special lunch and learns in Tasmania, and they are face-to-face, and I guess because of our geographical setup, it's quite easy for people to travel to a central location, and it's something that we've done for many years now, so it's a continuation of our meetings, and it works really well. It's well attended, and it's a semi-formal forum, if you like. We usually have a couple of speakers, then we break for lunch. We have an open forum session, and the discussion and the networking just flows between members, and it's really become more popular now that we've moved to the college because there's no treasurer's report to submit, and there's all those formalities have gone, so it's purely professional development, and it does work very well.
And I know that they've had success as well in Western Australia. The Western Australia
Yes.
Special Interest Group
Yes.
has had at least one or two now
Yes.
breakfast forums which have gone very well.
Yes, and similarly in the ACT, they have got a well-established group of people that meet on a regular basis for education forums.
So I guess the message to members is there's no reason why you can't do it.
No reason why you can't do it. We're open to all ideas that people want to, throw at us, and we're really happy to facilitate any activities that they'd like to see taken forward.
Thank you very much. And that's Annie Wells, who's the chair of the Special Interest Group Advisory Committee. I'm talking to Maria Geraja, who's the president of the college, and we're at the 2013 annual conference up here on the Gold Coast. And it's day one, and we've got over 500 delegates attending. One of the questions I'd like to ask you, Maria, is What's some of the messages that you'd like to give to the members about the benefits of being a member of our college?
I believe there are lots of benefits of being a member of the college. One of them is that you're part of a very big group of people that are infection control professionals or practitioners across the whole of the Australasia Pacific area. That it's about networking. You have an opportunity to network. We have over 1,000 members and it's growing. We have special interest groups and there are more special interest groups coming.
Just back a bit because the hand was in shot. But yeah.
So you talked about there's over 1,000 members. What sort of areas do they work in? So I'll ask you that question.
Okay.
Maria, you've said we've over 1,000 members. What sort of areas do they come from?
The ICPs come from everywhere. They come from acute care hospitals to non-acute care, residential aged care, rehab, private hospitals, country hospitals, GP practices, dental practices.
Is there anywhere where they don't work?
Tattooing, everywhere.
Yeah.
They come from everywhere.
One of the comments you talked about was the special interest groups. And we've seen some of these really start to take off in the last 6 months. What do you think are the benefits of the special interest groups for our members?
The benefits of the special interest groups is that if someone has an area of particular interest that they have, they can join that special interest group. Even if they're a novice person, they've got a very mild interest in it and they want to broaden their experience and knowledge, those special interest groups allow them that opportunity to network, to be part of a discussion list. There's also the state special interest groups where people can actually meet, either at breakfast journal club or seminars, and also be able to provide suggestions of future ongoing workshops that might meet their particular needs.
Maria, you mentioned that we have a journal. Would you like to tell us a little bit more about the College Journal?
The College Healthcare Infection Journal has been around for a while.
Stop there, we need some precise dates.
Oh, no, I won't. I'll take that out.
Yeah,
take that out. Just keep going.
No,
we'll add it.
Okay. Maria, you mentioned that the college has got a journal, and I believe it's called Healthcare Infection. Would you like to tell us a little bit more about it?
The Healthcare Infection Journal is a journal that ICPs, infectious diseases and microbiologists, anyone with an interest in infection control can publish their papers. We have an editor-in-chief, Brett Mitchell, who will be able to talk and embellish a bit more on what the journal has to offer for our members.
Thank you. We're at the conference, which is the second one that the college has run, and this is just as successful, if not more successful than our first one in Sydney. Maria, what are some of the benefits?
Take two.
Take two. What are some of the benefits for members of coming to one of our conferences?
The benefits to the members is really being able to be exposed to innovative ideas, innovative technology from our corporate sponsors, being able to network with other ICPs, being able to see great initiatives that have been taken to reduce healthcare-acquired infections that they may be able to take and model in their own facilities. Also being able to see and recognise that they're not alone. That there's lots of people out there, and even with the changes to the economic downturn in Australia, that people are still prepared to be passionate and sharing and want to come to the conference to be able to be exposed and have that opportunity as part of their professional development.
What else do you want to talk about?
The Executive Council. I think I want to talk about the fact that the Executive Council is, we've got a new Executive Council, we have a new President-elect, and that there are some new committees that are being developed, there's been some changes to the committee structures, the standing committee structures, and that will be, and that further information will be available on the college website.
Maria, the college has just recently appointed a consumer representative to its Executive Council. Tell us how you came about this groundbreaking move.
The National Steering Committee, when we were establishing the college, decided that we actually needed to be innovative and appoint a consumer rep so that it provided a balance in what the consumers actually need and want around healthcare-acquired infections. And it's actually something that I'm very passionate about engaging consumers and getting the right information out to consumers. And by appointing Mary Potter as our consumer rep, that's taken a big leap forward, and hopefully there'll be lots of positive things over the next 2 years that we'll see coming out of that.
Maria, would you like to tell us about the management of the college?
The college structure now has the President-elect, the President, the past President. We have 7 Executive Council members from the whole of Australasia. We have a consumer rep, we have a events and marketing manager, we have an operations manager, and we also have our secretariat. They provide the Executive Council and the Executive Management team provide the groundwork stuff that the college actually needs to be able to move forward and progress, particularly with the changes that are occurring in health today.
Maria, you were at the ACIPC conference in Shanghai this year and participated along with a number of other college members who were presenting. What do you think we as an Australasian college can do and learn from our region?
There's several things that we can learn. There are areas that aren't being supported in the Asia Pacific area, and I think we have a challenge now to, as a college, to actually support them, and that could be through mentorship and setting up special interest groups from anywhere in the Asia Pacific area that embraces New Zealand as well. And I think that there are opportunities for us to also work collaboratively in research, which we currently don't really do, and primarily being able to support those developing nations in the Asia Pacific area.
Maria, I'd like you to tell us a bit about Conference 2014.
Conference 2014 is actually in Adelaide in South Australia, in my hometown. It's a 4-day conference this time, and there are going to be some changes with the conference in that we're going to be looking at having our workshops like we normally do, but also having opportunities for our special interest groups to be able to meet and do some planning and some networking and basically meet face to face rather than just by teleconference or email. And the other days of the conference will definitely be very full-on days, but one of the things that we've done this year at this year's conference was having a networking breakfast, and we're planning on continuing that hopefully in 2014, where all ICPs will have a chance at the breakfast to actually meet, greet, not sit with their friends, learn, make new friendships, learn about the challenges that everybody has, and basically have an hour of being able to be relaxed and talk about anything and everything without actually having to worry about listening to anyone talk to them.